The content of my talk will be why I do an all-inside ACL reconstruction, followed by a debate on why I do a single bundle ACL reconstruction. We all graft tissue, graft size, initial fixation of graft, healing and biological remodeling of graft, and also post-op rehabilitations. Recently, the use of hamstring autograft has increased due to similar result as other graft, and one of the most common graft choice is quadruple hamstring. There are several advantages in using a hamstring. It has improved cosmesis, decreased patellofemoral complications, and also have less interference with nailing, especially in our Malaysian population. And it is technically easier in terms of graft passage and also reduce the problem with graft tunnels mismatch. However, with the use of hamstrings, we also face some major challenges, such as the graft being too short or too thin. So in the first scenario is, what happens if my graft is too short? What will I do? One potential solution to this complication is graft hybridization. However, clinical outcome is conflicting, and by using an allograft to supplement the inadequate autograft, you need to have some preparations work to do. Next possible one is synthetic augmentation. However, I don't think we are using it, and there's definitely a high risk of re-rupture. Another one would be harvesting another autograft. Is possibly one of the solution. However, that will give you donor site mobility, and also you may have problem in consent. And my preferred solution will be using an all-inside ACL reconstruction technique. So before we move on, we need to know the minimum length of the graft needed. For biological incorporations in the femoral and tibial tunnel, it's reported that we need around at least 15 to 20 mm, and it will give good histological maturity and also biomechanical strength of the tendon bone junction. And when we compare the standard technique with the all-inside technique, for the standard technique using a tibial interference screw and also the femoral cortical suspension fixation, we require a minimum length of around 90 mm. Whereas if we were to use an all-inside technique, holding the principle of around 20 mm in each all-inside technique if my graft happened to be too short. And now it brings us to another scenario. What if my graft is too thin? I think this is one of a very common scenario that most of us face when we start doing ACL reconstruction. It does happen especially in our Asian small size population. And I think all of us know that graft diameters has been correlated with the increased risk of re-rupture. And Magnuson et al. Has evaluated hamstring autograft diameter as a predictor for graft failure and also its needs for revision. And they found that any graft size that's more than 8 mm has a revision rate of 1.7%. If the graft size has dropped to 7.5 to 8 mm, revision rate is 6.5. And if the graft size is less than 7, has a high revision rate of 13.6%. And for me, my preferred solution is to alter the graft construct. This can be done by folding the graft more to increase the graft size, and there are several published techniques. What we can do to increase the size with different constructs, we can use both the semi-T and also the gracilis. By doing a 5 or 6 stranded construct, it all depends on the graft size and also the graft length we get from there. And when you do a search, you can see that there are several different techniques that's published, and these techniques use an increased number of hamstring strand to increase the graft diameter. So I guess we are all very concerned about the biomechanical properties with all these new construct. So this is a very good paper. It's a biomechanical comparisons of alternative graft preparations for all inside ACL reconstruction. They actually compare 6 different grafts with the traditional 4-stranded graft. And they found that there's no difference biomechanically in cyclic loading and also ultimate force of displacement. How can an all-inside ACL reconstruction maximize our graft size? We can obtain a shorter sockets by doing a retrograde drilling for both the tibial and also the femur. And with a shorter sockets, we require a shorter prepared graft. We need a 6 to 7 cm compared to a 11 to 13 cm. And also we know that it's biomechanically strong compared to the various construct. And also we can potentially save a gracilis tendon. And in all-inside technique, we create sockets but not tunnel. Therefore, it is more bone preserving and cortex sparing. And this paper will say that all-inside technique is less painful in early post-op with less bone edema. Why I do an all-inside ACL reconstruction? It allows optimization of graft size, and usually it's enough to just harvest the semi-T, which lead to less mobility and preserve a flexion strength. And it also allows final tensioning, and it is a bone preserving technique which lead to less early post-op pain and also good for multi-ligaments reconstruction where you want to preserve as much bone as you can.
And now is a mini debate between double bundle versus single bundle ACL reconstruction, and I'll explain why I do a single bundle ACL reconstruction. It is well known that ACL may be divided into two functional bundles, the AM and the PL bundle. Double bundle ACL reconstruction attempts to restore both the AM and PL bundle, with the aim to restore both anterior and rotatory control. So let's look at the evidence. In biomechanic testings, few studies reported that double bundle technique reproduced knee stability and kinematics closer to the native knee. However, other studies showed that double bundle reconstruction did not offer significant advantages. This paper published in AGSM performed a biomechanic studies comparing anterior translation and pivot shift stability in double bundle, anatomic single bundle, and non-anatomic single bundle ACL reconstruction. The results showed that the double bundle and anatomic single bundle ACL reconstruction demonstrated significantly improved rotational stability compared to the non-anatomic single bundle ACL reconstruction. There's no difference between the anatomic double and single bundle reconstruction. And when it comes to clinical outcome studies, evidence are also inconsistent. Some literature indicated that double bundle technique could acquire better knee stability but get comparable post-operative function compared to single bundle technique. On the other hand, several researchers found that both knee stability and clinical function has no significant difference between the two techniques. Most published studies have inadequate descriptions of the operative techniques in which the same graft type and size and locations of insertion sites were not controlled. To close the gap, this study compared anatomic single bundle versus double bundle ACL reconstruction with a standard graft size, and it shows there's no difference in clinical outcome. And when it comes to rotational stability, doing a double bundle ACL reconstruction do not completely solve the problem of rotational instability. Up to 30% in both double bundle and single bundle ACL reconstruction have persistent pivot shift. This is thought to be due to the anterior lateral complex injury such as the ALL, ITB, and also lateral meniscus, and so there's a renewed interest in a lateral tenodesis procedure. The most common cause of failure is improper positioning of bone tunnel. The double bundle procedure, which is more complex, would be expected to be associated with more mismatched tunnel and poor outcome. There's also an increase in surgical time for double bundle procedure. Apart from what we have discussed just now, other advantages of single bundle include lesser post-operative pain, lesser tunnel widening problem, and this will lead to easier revision, and lesser problem with graft size, and also a lower implant cost. And in conclusion, my preferred technique is single bundle all inside ACL reconstruction. It allows optimization of graft size, lesser mobility if I just utilize semi-T, is more bone preserving, and I do not need a double tunnel that potentially give double trouble, especially in our Asians small size knee, and also consider a anterolateral procedure if needed.
Thank you very much for your attention.